also have to prevent the complication of disease. So it's the up and toss, and then in our society there's a lot of diabetes. So what we're going to do, we want a drug which will control at least the complications of the disease, but that too with safety first. So whatever I'll be talking about, and we are talking from the routine slightly differently, because in a time and era of the modern drugs available, me talking, as you all know, I'll be talking about a molecule which has been with us for a long, long time. And I'm kind of reinventing the wheel. That let's talk about the sulfonylureas in the presence of other drugs which has shown already so much improvement in terms of lives of people with diabetes. But there will be two or three reasons which you need to understand and which you need to probably keep in account that while we are talking about a drug which has been with us. So we'll be talking about sulfonylurea. So major goal of anti-hyperglycemic therapy is safety, glycemic control, of course, but then, as I said, reduce the end organ protection. And when we talk about these, there are a few things which comes to mind. We want to prevent nephropathy, we want to prevent cardiac issues, we want to prevent retinopathy. We want to do all this not at the cost of hypoglycemia, for sure, not at the cost of hypoglycemia. And we want to do all this not at the cost of weight gain. So keep these three things in mind, and I'll take you with me on this journey of why we want to discuss this today. What does the guideline say? Well, this is the famous guideline of American Diabetes Association. And if you look at, I'm not going to argue or talk for or against the common scenario which these guidelines show, which is that if you've got atherosclerotic vascular disease, if you've got a heart failure, if you've got a kidney failure, what to choose. I'm not going to go into details of that. You all know that, what to use. But what is on the other side is important, and that is that you need to use a drug if you want to achieve the goal. And there are different kind of drugs, and one of the drugs which comes in that is GLP analogs, which have got a very high potency for reducing the glycemic, a good glycemic control. But then there are other drugs, and including in those drugs of high affinity is sulfonylureas. But something which the West tells us to forget about it. And I'm going to tell you a reason why we must not forget about sulfonylureas. I'm going to tell you a reason as we go along, and I'll take you with me. Let's look at the other guideline. This is International Diabetes Federation. International Diabetes Federation is an organization which is not corporate organization. You know, you talk about Americans, corporate organization, talk about big, talk about expensive, talk about, very lucrative kind of guidelines and medication. But IDF look at the whole world. So looking at the whole world, they look at initial therapy, which is metformin, of course. But then they say that if you've got a very high A1C, and we keep on looking at these guidelines, whether you look at ACE guidelines, whether you look at American diabetes or European guidelines, they all say if you've got a glucotoxicity, if you're catabolic, start insulin. But IDF recognizes that not everybody is for insulin. Even if I say and argue for the patient, you say and argue for the patient wouldn't like to start insulin right at the outset. Some of the patient might, but majority of them don't. You know that, this is reality. So the IDF keeps that in mind, and what they say is that if you want to start somebody who's starting off with a high A1C, start them on 2 drugs. Very common, good combination, and use the drugs which are safe, and use the drugs which have got a good potency to bring the A1C down, right? So that's the initial. So if you look at these initial combinations, what it says is 7.5 to 9, use metformin and sulfonylurea. IDF is beyond ADA. IDF is beyond ACE. It looks around the whole world. So SU and metformin, if it doesn't, or metformin DPP4, metformin SGLT2. I'm not going to go into details, you all know about these drugs, but what I'm saying to you, the principle of it, that the organization will look at a richer and a poorer and lower middle income countries. This is the recommendation you have, and you have got SU. Whereas when you look at the corporate and at the, the American kind of thing, there was no sulfonylurea. And I'll give you another reason for that as well. So if it doesn't work, use a dual therapy, and which adds secondary, if you've used this, use sulfonylurea, and so on and so forth. So what I'm trying to present here is that regardless of where you are living in the world, you want to use a drug which is safe, and you want to use a drug which is effective and which brings the numbers down to prevent the complication right at the outset. And this is what the IDF algorithm tells us. So I'm not going to go in detail, but we know that the drug to start off is metformin, and now in this era we've got a wonderful drugs in terms of DPP4. We've got a GLP-1 analogs, expensive but available, and we know that they've got a good cardiac safety and renal safety, and same applies to SGLT2 inhibitors. So these are all available to us, and I'm not suggesting at all that you're going to disregard this. No, you cannot disregard this at this time and era. It will be very foolish to disregard these drugs. So these are available to us, but what I want to bring you is to drugs which we have forgotten about. There's been so much negative propaganda against these drugs, and one of them is sulfonylurea. So there are three kinds of sulfonylureas available, which is glimepiride, gliclazide, and glibenclamide, good old glibenclamide. And if you look at the trials which are done in initial days, what trial would come to your mind, which is a main trial which has changed the outlook of diabetes? Which trial?
UKPDS.
UKPDS. What drug was used in that? Glibenclamide. And it shows so improvement, 1% drop, 21%, 31%, so on and so forth, reduction in microvascular and amputation and so on and so forth. What drug was used? Glibenclamide. But we have grown out of that era, and we've got other drugs. So the next question is, there are three sulfonylureas available. Are they all the same? They are not. Because gliclazide stands out, and sometimes I tell them that gliclazide is not sulfonylurea, and the reason for that is if you look at the difference between the three molecules, and starting from glibenclamide, which is very old, common, cheaper, tested for a long time, long chain, but it has got affinity for sulfonylurea receptor 1 and receptor 2. And receptor 1 is on our pancreas and receptor 2 is everywhere else. And that's why some of the effects, bad effects of glibenclamide or sulfonylureas are overall on the body in terms of cardiac issues related to cardiac preconditioning, because it has got affinity both for SUR, SUR2, and same applies to glimepiride. There is a slow reversibility at SUR level for both glimepiride and glibenclamide. That's important to understand. What does the slow reversibility mean? Which means that if it attaches to SUR1, which is at the pancreas where the insulin is released, the reversibility protects person from going into hypoglycemia. And they have got a slow reversibility, which means the chances of hypoglycemia are very high. And as I said, the selectivity for pancreas is pretty low for the two drugs, glimepiride and glibenclamide. More so for glibenclamide, but less for glimepiride as well. But let's talk about the gliclazide. This is another molecule, and that's why I say this is not sulfonylurea. This is somewhere else. I don't know where to put it, but because it works on pancreas, that's why we put it in the sulfonylurea class. So it's a short chain. Straight away, the difference between its structural properties. It has got a higher affinity for sulfonylurea receptor 1, which is at pancreas. And more importantly, it is reversible inhibition for SUR1 receptor. What does it mean? It means just like a DPP4, just like a GLP-1, if the glucose goes high, there will be a high release of insulin. But when the glucose goes down, there is a reversible inhibition of SUR, which means the chances of hypoglycemia are pretty low. Is it just theoretically I'm talking about? We'll see that in the trial. That does it reflect and shown in the real world as well that there's a low reversibility, reversible inhibition of SUR because it is very selective to pancreas. It doesn't finish here. We talk about that if you'll all agree, there are people with interest of diabetes and cardiology and all that. You will all agree that we want to use a drug which protects pancreas. One of the drugs which protects or reduces apoptosis is GLP-1 analog. We also talked about DPP4. It reduces apoptosis, at least in the animal model. So does this drug with reversible inhibition of sulfonylurea receptors, SUR1, reduces the apoptosis? Yes, it does. It causes reducing the production of ROS species and reduces the apoptosis. And the evidence of that is shown in this slide, which means that if you start somebody on sulfonylurea, the chances of getting to insulin treatment is different for somebody who started on gliclazide than compared to somebody who started on glibenclamide, because the exhaustion of the beta cells is quicker when you are using something beyond gliclazide. And in this case, gliclazide takes around 5 years to start somebody on insulin. So that's something very positive, to say the least. Now, if you're using a drug which causes reversible attachment to pancreas, causes less hypoglycemia, causes less apoptosis, causing delay in the use of insulin, does it have any effect on A1C? Well, look at the A1C reduction. Compared to all the other drugs, gliclazide shows a very good reduction in A1C. You want to start something as potent as it could be to reduce the A1C. And it is as compared to, probably repaglinide is the only one which is slightly better than gliclazide, but with all the others, the power of reduction of A1C is much good if you're using gliclazide in the start of the treatment. That's number one. Which is the trial, or which is the, in clinical scenario, trials which one would say are very good trials? Which trials are very good? In a model of using a trial, which kind of trials are better? Observation trials, RCT trials. Which is the second best? The second best is the real world data. So if you haven't got an RCT, and the RCT evidence came pretty late, and now we know that RCTs are the best trials. So what the second best you have is the real world data. This is a real world data trial, and what it shows was people using post hoc analysis of 7,770 patients used in 8 countries, and what it shows was if you are using sulfonylurea in terms of their treatment with combination or without combination or switch from other sulfonylurea to gliclazide, the reduction power of reduction in A1C is very potent in terms of gliclazide when you are comparing with all the other drugs used. And we know that 1% reduction, as I said, the UKPDS trial, that you reduce 1% of A1C and you see big improvement in all these parameters, including the microvascular and lower extremity amputation, heart failures, and so on and so forth. So 1% reduction is good. In a real world easy diet study, we've seen a 2% reduction in A1C. It doesn't finish here. So often we see patients who present to us with very high A1C. So if you are coming across a patient who present to you with A1C of 10 or 11, the bigger the A1C, the bigger the drop you're going to get. So this is again easy diet study. So if somebody has got a larger A1C, the drop in A1C is even bigger, and so on and so forth. So it doesn't finish just that the drug is good, but it's also important that in your naive new patients who are reluctant to use insulin, where, to be honest, I would use insulin to begin with. But you and I know it's very difficult to convince them to use insulin right at the outset. And they will say, Dr. Saab, abhi to mujhe sugar hui hai, insulin to bahut aakhir mein shuru hoti hai. So then you want to use drug which is safer, which reduces apoptosis, and which has got a good drop of A1C, as I've shown you here, that in the newer patients, the higher the A1C, the bigger the drop you're going to get. The next point, as I've shown you in the first 1 or 2, 3 slides, is the safety. And the safety is that whether using this molecule will cause weight gain. Now, in this again easy diet trial, in fact, what they saw was a reduction in A1C plus reduction in weight. We would welcome any drug which reduces A1C and also doesn't cause the weight gain. And one of the reasons, from my pathophysiological understanding, is that you drop the weight when there's less hypo. That's very classical. The endocrinologists who work, we know that the hypo causes defense mechanism, which means people eat, and because of their eat, the glucose goes up, and because of that protective mechanism, you will gain weight. So if a drug doesn't cause much of a hypo, the chances of that drug causing weight loss is pretty high. And I think gliclazide stands out in this real world data. When you compare with gliclazide with glimepiride in this GUIDE study, what it shows was that it's as effective as glimepiride in terms of comparing the two molecules, but this effectiveness didn't come at the cost of hypo, and there was less hypos in patients. So any good control must not cause weight gain and must not cause hypoglycemia. And I think that's why gliclazide stands out of all these sulfonylureas that we've been talking about. So we talked about safety. We want a good reduction, which we have seen, and we also want to see a reduction in the end organ damage. So the one of the organ which many people talk about, and these days, a lot of talk is about the cardiovascular and nephro outcomes. So is there any evidence of renal protection? Yes. Advanced trial, which has been published back in at least a decade ago, has clearly showed 21% reduction in new worsening of nephropathy, and that's not the only one. It also showed 65% reduction, which was not statistically significant, but clinically significant end-stage renal disease. But reduction in new onset or worsening of nephropathy was clinical and statistically both significant, and that's why you would see the advanced trial being projected time and again for the protection of kidneys, which has been shown. If you compare this with any other drugs, it stands out, except, of course, the newer drugs, SGLT2, which has shown more reduction in the worsening of macroalbuminuria, which is more than what was seen in the advanced trial. But overall, if you look, the reduction to end-stage renal disease is much superior for gliclazide compared to any other class of drugs which we have seen. So we have seen the benefits of this drug, and also at the not at the cost of a hypo and not at the cost of weight gain. Ramadan is around the corner, so our next worry is that are we giving a drug which will cause hypoglycemia? Now this is a Ramadan study. This was a study done in 8 countries, and Pakistan was one of them, and I was part of this trial, which was published later on and in the International Journal of Clinical Diabetes and Clinical Practice. What we showed was the low rate of symptomatic hypoglycemia and type 2 diabetes on gliclazide MR during Ramadan fasting. So another support for us. Ramadan is around the corner. So of course you will change the timing of the dose as you would for any sulfonylurea. But the chances of hypoglycemia are pretty low because what I've shown you right from the beginning, because of the reversible affinity for SUR1 receptor. So what I'm saying is not theoretical, it is actually the pathophysiological evidence that we have that it causes less hypoglycemia. We did a sub-analysis of our own patients, which was done again in Dia Ramzan. So Dia Ramzan was 800 altogether patients in the Malaysia. Malaysia was with us, Bangladesh, Pakistan. Pakistan had the maximum number of patients. So this was a sub-analysis of our own patient, and again, the A1C reduction was significant, and the fasting reduction was significant, and all this didn't came at the cost of a hypo. That's important. For Ramadan, this is the one thing which we don't want. So Ramadan is around the corner. You need to be pretty safe and pretty confident to use this drug. If you want to use, or your patients are already using any sulfonylureas, and then you want to switch them over to a drug which is safer than the sulfonylurea that we have. A few years ago, I think it must have been, I think 4 or 5 years ago, we in South Asia got together and talked about that why sulfonylureas have been out of all the guidelines. So we said that let's talk about sulfonylureas. So we all, safest countries, which includes Pakistan, India, Bangladesh, Nepal, Afghanistan is now included. So we all, Sri Lanka, we all got together and we said let's have a recommendation of our society for sulfonylurea. And the reason, one of the major reasons for that was cost effectiveness. You and I know that sulfonylureas are cost effective. They're potent. But one of the things which puts us off is the guideline doesn't say anything about them. In fact, the guideline discourages us. If you look at the ADA or European guide, they just, not the European, but the ADA particularly, they just discourages us to use the sulfonylurea. So we said, let's get together and let's talk about based on the scientific evidence. So as a result of that, we publish this, which is published, it's on the net, it's available. And this is the place of sulfonylureas in the management of type 2 diabetes in Southeast Asia. Abbas Raza, myself, Sanjay, we were all part of this, and we published it, and it, as we speak, it gets a lot of citation because people talk about this these days as of, this is being used in Southeast Asia. And what we said was, considering their efficacy, safety, and pleiotropic benefit, the low cost of sulfonylureas should be considered as recommended therapy for the treatment of diabetes in South Asia. And one of the reasons for that is we are low income countries and we cannot just disregard sulfonylurea. So this initiative aims to encourage rational, safe, and smart treatment as you and includes appropriate medication counseling. So, as I said, treatment should be safe. We want to avoid the weight gain and we want to avoid the hypoglycemia. If you look at this guide study, which was done by Al-Sifri from Saudi Arabia, is a good colleague of ours, and he compared all these sulfonylureas and wanted to see in fasting what happened. And we have shown this again in Daya-Ramzan study, that there is a less chance of hypoglycemia. And he has shown this some time ago, in fact in 2011, that gliclazide, out of all sulfonylureas used in Ramzan, causes least hypoglycemia, to say the least. We talk about the CV and renal and other complications. This is the article published in pretty recently, 2022, evaluation of gliclazide for treatment of type 2 diabetes. And what it says, the highlights, is the cardiovascular outcome studies have shown no evidence of increased cardiovascular events with gliclazide, and durability of glucose lowering is comparable to other drugs, no surprise. And they differ in SU receptors and beta cells, pancreatic cells receptor selectivity, which I've just mentioned. Now this is the difference. You know, you cannot say a blanket statement to all the sulfonylureas. This sulfonylurea is different than the glimepiride and glibenclamide. Compared to other sulfonylureas, gliclazide showed a favorable profile for glycemic efficacy and durability and risk of hypoglycemia. And very interestingly, they said that low doses of gliclazide may provide an incretin effect, which may be useful option for many patients. And same incretin effect is actually seen in metformin as well. I must mention that here. So this is cardiovascular diabetology, a review of 118 randomized trials. Showed that gliclazide was associated with lower risk of all-cause cardiovascular mortality compared to glibenclamide, suggesting a possible benefiting specific effect of gliclazide. Real-world usage of SU in Asian patients using the JADE Giant Asian Diabetes Evaluation, and what it shows is it was used in 11 Asian countries, a big number of patients, 62,000. 59% received SU, and 50% of them used gliclazide, showed less hypoglycemia and better outcomes in terms of A1C. Combination with metformin was most popular choice in terms of health quality related outcomes. This was by Kamlesh Koti, who's a GP in UK, and those of us who work in UK, gliclazide is one of the molecules which is used very commonly in Britain, even in these days. And they mentioned about role of gliclazide MR in the management of type 2 diabetes, and what it shows was that gliclazide treated patients had lower rate of hypertension, dyslipidemia, peripheral sensory neuropathy than those receiving other sulfonylureas. And that's why I keep on saying that we are putting gliclazide in the categories of sulfonylurea, but the properties it exhibits are much more than simple sulfonylureas that you and I know. Cardiovascular safety and type 2 diabetes with sulfonylureas as a second-line drugs. And to me, this was published last year. To me, the most interesting part was that safety of sulfonylureas published in Diabetes Care, American Journal. To me, this was interesting part, because in American journals, where the guidelines of ADA prevail, they have shown that contribute the understanding of second-line sulfonylureas for glucose lowering are unlikely to increase the risk, cardiovascular risk, or all-cause mortality, given their potent efficacy, microvascular benefit, cost-effectiveness, and widespread use. This study supports sulfonylurea should remain part of the global diabetes treatment portfolio. So, better late than never. Published in Diabetes Care, an American journal. So that's, for me, this is very reassuring that they've started to listen to what the rest of the world is saying. One of the major problems, you and I would agree, is the compliance of drugs when you're using. So if you're talking about sulfonylureas, GLP, SGLT2, DPP4, the lowest rate of discontinuation of the drugs is with sulfonylureas and particularly gliclazide, whereas the highest is with GLP-1 receptor agonist, and then so on and so forth. So that obviously explains that, the side effect profile, if the patient is comfortable, they would rather like to continue the drug. And sulfonylureas, among sulfonylureas, with the properties which I've just mentioned, I would be very confident to use a sulfonylurea which causes a good compliance, which makes patient a good compliance, and also reduces the side effect profile, and patient doesn't leave the drug that too often. In terms of cardiovascular safety, advanced trial has shown that it doesn't cause increases. UKPDS has shown neutral effect, and Carolina and Tosca, in which sulfonylureas was used, again didn't show much of the cardiovascular risk that we've been talking about so far. So we need to reposition our drug list again, keeping in mind all these points which I've just mentioned, and I'll be happy to discuss if any question arises. But the important part is that initial combination therapy with metformin, as I've shown you in Easy Diet trial, reduces the A1C pretty effectively. And I think initially when you get a powerful drug which reduces the A1C safely, I'll be very happy with that drug. So SU and gliclazide MR stands out in that. It may be used as a third line agent if nothing works and you're using other drugs to begin with. Second generation, especially gliclazide, is safe in generally in population and also in elderly. It is cautious to be used because you need to change the timing during Ramzan, and as I said, Ramzan is around the corner. And if the person is using a sulfonylurea, you want to make sure that you want to use a sulfonylurea which is safe in Ramzan. And as we've shown in that Ramzan, and then we have published our own data of gliclazide MR, which has shown the safety in Ramzan. And it can be used safely without dose adjustment in patients with renal impairment up to CKD stage 4, but you may have to use a slightly different combination, maybe a simple combination for that. So now comes the question, and I raised two questions. One of the questions was why ADA didn't mention gliclazide in their recommendation. And anybody who would know that would get an extra cup of coffee. Anybody? Because gliclazide is not available in America. This is European drug. It's not available. So they don't even talk about this. And that's why if you talk about ADA guidelines, there will be no mention of gliclazide because it's not available. And they haven't licensed it to be used. Because to license going into FDA and all that, this drug is much older and much potent used in European and Asian countries. And it is not, that's why in the ADA guidelines. But we have seen that IDF did suggest that you can use sulfonylureas in your algorithm. And IDF is seeing the whole world, not American people only. And that's why it's mentioned in their guidelines. If you look at WHO guidelines, WHO has a list of essential drugs. And that WHO model list of drugs includes metformin and gliclazide. Because WHO looks for the whole world. So, in conclusion, ladies and gentlemen, I would say sulfonylureas remain a good choice for a population in a country like ours, where people struggle to meet ends, and you need to use a potent drug which works effectively, and you want to use a drug which is safe. As bad name as one can give to sulfonylureas, not all sulfonylureas are the same. That's my message. Thank you very much.